Thank you for joining for the Myeloid Disorders lecture for the Hematology and Oncology unit of the General Medicine course. Please be sure to have your study guide with you as you complete this recorded lecture so you can be prepared for the application session. Please be sure to review the learning objectives for the myeloid disorders to make sure you are ready for the exam. When discussing myeloid disorders, it's important to look at the development of hematopoietic stem cells. In this lecture for myeloid disorders, we will be specifically talking about this portion of the chart, the myeloid line. You've already had a lecture on red cells or erythrocytes, and also we've had a lecture on hemostatic disorders, which involves issues with the thrombocytes. So today, for most of the lecture, we'll be talking about the cells that come from the myeloblasts, specifically basophils, neutrophils, eosinophils, and monocytes. We will see in some of the disorders, however, there are issues also with the erythrocytes as well as the thrombocytes for myeloid disorders. Here's another representation of the divisions of hematologic malignancies. For the lecture today, we will be talking about the myeloid disorders, which are all the disorders here from the myeloid line. The myeloid disorders are divided into acute myeloid leukemias, and then also further divided into chronic myeloid disorders. Chronic myeloid disorders can include things such as chronic myeloid leukemia, chronic myeloproliferative disease, myelodysplastic syndrome, as well as a variety of other atypical chronic myeloid disorders. Before we talk about specific myeloid disorders, we'll first discuss leukemias. Leukemias are a malignancy of the progenitor cells of either the myeloid or the lymphoid cell lines. The type of cell or cell lines that are involved will dictate the type of leukemia, the name that's used for it, as well as the presentation, diagnosis, and treatment. It's very important to distinguish which cell line you are dealing with when you're working up and treating a patient for leukemia. Leukemias are caused by an acquired somatic mutation of the progenitor cells. These cells, or abnormal cells, will start to accumulate in the bone marrow, leading to the issues that we see with leukemia. We often refer to these abnormal accumulating progenitor cells as blasts, meaning that they are abnormal immature cells. We will often use the term blast throughout this lecture. As the blasts start to accumulate in the bone marrow, they will later start to spill over into the peripheral blood. And once the blasts have filled the peripheral blood, later in the disease state of leukemias, we can even see the blasts start accumulating in other organs and tissues. The biggest issue with blasts is that they're non-functional cells. So they actually start taking the place of all the normal cells and stop their production. So later on in the disease state, we see issues with pancytopenia, meaning that the body is unable to produce white blood cells, red blood cells, and thrombocytes because all the blasts have started to take their place in the bone marrow. Each type of leukemia can have slightly different presentation, but in general, providers will see many of the same signs and symptoms in all patients with leukemia. Some symptoms include fever, chills, and night sweats. You may also find patients have fatigue and weakness. Infections are common in patients with leukemia because these patients have their good white blood cells pushed out by the blast cells. Patients often present with some sort of weight loss, and patients may also present with lymphadenopathy or hepatosplenomegaly. However, lymphadenopathy especially is more common in lymphomas than leukemias, but it does still occur. Because of issues with production of platelets, we also will see symptoms such as petechiae, purpura, or other bleeding such as epistaxis, and again, that's due to low platelet counts. Patients may also present with bone pain or tenderness, and this is because of the large amount of blast cells that start accumulating in the bone marrow. First, let's discuss acute myeloid leukemias, sometimes also called acute myelogenous leukemia. Acute myeloid leukemia is a malignancy of the bone that involves an increased number of immature myeloid cells in the bone marrow. Again, we refer to these cells often as blast cells, specifically myeloblasts in the case of acute myeloid leukemia. This is due to a chromosomal molecular abnormality. Eventually, this leads to increased blasts and eventually pancytopenia, which causes the patient's good cell lines to no longer be produced. So we will have a pancytopenia with circulating blasts or abnormal myeloid cells or myeloblasts. Ultimately, the number of blasts and types of blasts circulating determine the kind of leukemia. AML is classified by the French-American-British classification system, which is listed here for you. You can see in the list here that each type starts with an M, which is because this is a myeloid line disease, so there's problems with abnormal myeloblasts. And you can see that there's different numbers for all the different variants. And different variants are caused by different types of blasts. You do not need to memorize the specific classification levels or which type of leukemia they are associated with one exception, the highlighted one, the M3 AML, also called acute promyelocytic leukemia or APL. I do want you to be familiar with this type of leukemia, and we'll be talking about it more in depth shortly later in this lecture. AML has a variety of potential etiologies. Some of the causes of AML can be idiopathic, meaning that it is due to a spontaneous mutation of the cells. There are some other causes of AML. Another common cause is a congenital abnormality. This is especially seen in patients with trisomy 21 or Down syndrome. This is because those patients have a third copy of the 21st chromosome. And this leads to an increased frequency of both AML and ALL for these patients because the gene mutation occurs on that specific chromosome. We have also seen that radiation exposure can cause AML. Typically, this happens about 5 to 7 years after radiation exposure. And we first discovered that radiation would cause AML after the bombings of Hiroshima and Nagasaki. Chemical exposures are also a significant risk factor for AML, specifically exposure to smoke, benzene exposure, and petroleum. But there's also concerns for exposures to pesticides and herbicides and implications of causing AML. Some drug therapies may also cause AML. This is specifically chemotherapeutics. So patients treated for one cancer and then ends up with AML or this leukemia as an adverse effect of a treatment. Below are some of the clinical features seen in patients with AML. Features of cytopenias or low cell counts. Some cytopenias will involve anemia, others will involve thrombocytopenia. In addition, we also may see leukocytopenia or leukocytosis. This really depends on what type of cell, specifically white cell, you're looking at. Anemias will cause fatigue and dyspnea on exertion, as well as the many other symptoms that we've talked about in anemia's lecture. The main concern with thrombocytopenia is bleeding concerns. For leukopenias, or low white blood cell counts, this often causes a big issue with fevers as well as risk for infection. Leukocytosis is due to the increased circulating blasts. So this is actually not a leukocytosis, but a blastocytosis, which can cause a blast crisis, meaning that there are too many blasts, which we'll be talking about later in this lecture. Leukocytosis is especially concerning because patients can have increased blasts that start infiltrating into other tissues, such as the lungs or into the CNS, causing cerebellar dysfunction, in the eyes, causing blindness, into the spleen or the liver, and even can infiltrate into parts of the skin, causing what is known as leukemia cutis. And we can see a lesion with this that can be flesh-colored to violaceous in color where the leukoblasts have infiltrated the skin. And again, we may also see lymphadenopathy due to infiltration of these blast cells into the lymph nodes. Patients can experience bone pain, as we discussed earlier, related to the overgrowth of blasts within the bone marrow. And a common symptom that is a frequent question on the board is gingival hyperplasia, or swelling of the gingiva, which is also caused by infiltration of these blastocytes into the gums, and sometimes can be the first symptom that we see in a patient with AML. In AML, you can also see hyperuricemia and tumor lysis syndrome when patients are treated. So the patient starts chemotherapy for AML, and a bunch of cells are killed off very rapidly with the chemotherapeutic treatment. And the metabolic byproducts that build up after the bad cells are being killed off can cause us to see this severe syndrome in patients. Some of the symptoms they might have will include things like dysuria, oligouria, hematuria, hypocalcemia, and with that you may see things like tetany or vomiting or cramping. We can see mental status changes, as well as symptoms of hyperkalemia. These would include things like weakness or paralysis. The lab workup for patients with AML will often start with a CBC and is usually followed up by a peripheral smear. On the peripheral smear, the provider would see a pancytopenia with circulating blasts. In most cases, providers will often start with a CBC first, and then the result will show an increased white blood cell count. This is because the machine that does the CBC cannot distinguish blasts from normal white blood cells. So the provider will need to follow up on the leukocytosis finding with either a peripheral smear and also possibly a manual differential. Bone marrow exams for patients with AML are very crucial. They're critical for getting the proper diagnosis and staging of disease. Bone marrow is sent for both flow cytometry and cytogenetics, and one of the criteria for diagnosing AML is that there's 20% or more blasts in the bone marrow. Other tests you may order include chemistries. These will include things such as electrolytes, kidney function testing, calcium, phosphorus, uric acid, liver function panel, bilirubin, LDH, amylase, or lipase levels. Clotting studies are also very helpful for staging of patients. PT and APTT are usually included in this, but you will also might consider ordering a D-dimer in some cases. Viral serologies are important to order for the patients because they're in an immunocompromised state with AML, and so you want to make sure you test for things such as CMV, HSV, and varicella titers to look at their risk for other infections. Providers should also do a type and screen for patients, as they are likely to need transfusion support during their treatment, and HLA typing is done for patients who may have a stem cell transplant. Usually for HLA typing, this is a parent or sibling in many cases, as they may serve as a donor. Again, bone marrow is really what gives you the diagnosis of AML. The bone marrow will be hypercellular and dominated by blasts. Other diagnostic features of the marrow would include greater than 20% blasts, as well as a finding known as Auer rods. We'll be talking about Auer rods in the slides coming up. Some other studies that are very important to run for the bone marrow and the bone marrow aspirate and biopsy will be flow cytometry and cytogenetics. And this will involve doing karyotyping and possibly fluorescence in situ hybridization to identify the chromosomal abnormalities for that particular patient's AML. Flow cytometry is actually looking at cluster differentiation, or CD antigens, which are antigens that are on the surface of cells. These are actually glycoproteins. These are important because these markers will help the provider identify the cell line and what stage the patient's disease is at. This will help them figure out what type of cell is causing the blasts. Again, the main diagnosis criteria for AML is that greater than 20% of the marrow is dominated by blasts. Another finding that may show up in AML is the Auer rods. Auer rods are in the photo here. I'm going to circle a couple for you. So this cell has a bunch of hour rods in it. Those are those little strands that I just circled. And what these are little rods. They're also known as aerophilic granular material, and they show up in the cytoplasm of blast cells. They're called aerophilic because these little strands take up a certain type of stain called the Romanowski stain, and it is a very specific burgundy color, and it's common to see these types of blasts in AML. The hour rods are considered 30% sensitive and 100% specific for AML. You may see them in some other types of leukemias, but overall, when you hear hour rods, you should be thinking AML. As we mentioned before, flow cytometry and cytogenetics are also really important in the diagnosis of AML. On this slide, you can see some examples of the cytogenetics that may show up in AML patients. It's important to know a couple of these, and I would recommend being familiar with the types that are considered favorable. They're bolded and underlined on the slide. And with specific attention to the first two types, which are the translocation of the 15 and 17 chromosome and the translocation of the 8 and 21. So these two right here. You should be familiar with those. Again, you can see that for the second translocation, this involves the 21st chromosome, which is why we tend to see AML a little more in patients with Down syndrome. It's also important to know some of the poor prognostics for AML. I have a couple of them listed here for you. The one that I'd like you to be most familiar with is this isolated monosomy of either the 5th or the 7th chromosome. Also knowing that if it's a really complex karyotype, meaning that it has multiple abnormalities, greater than 3 is considered a poor prognostic indicator. There are also some other important items in the evaluation and management of AML that should be considered, and many of these should also be done in other types of leukemias, so it's not just for AML patients. Providers should consider doing cryopreservation of any viable cells that they can find in the patient. So if the patient has any good cells, these should be preserved in case they need to have a stem cell transplant later. Although an autologous transplant is generally not recommended in these patients, if they do not have a donor available, this may be considered. The reason we try and avoid autologous transplants in patients with leukemia is because if even one bad contaminated cell gets in there, then they could have a bad transplant with bad cells. These patients also will be having chemotherapy, so they should be having an echocardiogram and a chest x-ray to be sure that they are good candidates for different types of chemotherapy. Patients should have a central line placed so that they have access and are able to receive chemotherapeutics. We also recommend these patients undergo a dental eval, possibly lumbar punctures if there's CNS involvement. Usually this is more for patients with ALL. We'll be talking about that later, but it may be necessary for some patients. An MRI screen of the spine is usually going to be important in patients as well to make sure that they do not have involvement in any of those areas, especially if they're going to be having any CNS treatments. And of course, other items such as social work and counseling is very crucial for these patients. These will include things such as counseling on the disease, as well as financial counseling and referral for support groups for these patients. The treatment of AML is divided into two different groups, the treatment of non-APL AML and the treatment of APL AML. APL stands for acute promyelocytic leukemia, and again, this is the AML M3 on that grading system. For the treatment of the non-APL AML, so everything except for the M3 AML, patients will have first induction therapy with chemo, and the induction is just the initial chemotherapy that they have. That's what the word induction means. So they will start off with cytarabine and anthracycline in most cases. These patients will also require supportive care, mainly through transfusions, and this will be for any cell line that is low, as well as prophylactic antibiotics and antivirals to make sure they are not at risk for infections. It's also important in the non-APL AMLs to get a day 14 bone marrow. So this involves doing a bone marrow sample again after the 14th day of chemotherapy to check the blast count. If the patient has less than 5% blasts in the marrow, then it's okay to give them some granulocyte colony stimulating factor to try and get some of their good cells back up. The patients will continue the treatment with chemotherapy at varying lengths depending on their disease. The criteria for a complete remission of AML in patients includes a normal peripheral smear with the resolution of all cytopenias, as well as a normal bone marrow without any blasts. About 80 to 90% of adults under the age of 60 will be able to achieve complete remission. And we see about 50 to 60% can have complete remission if they're over the age of 60. There's often a consolidation treatment done for patients. So they'll have reached remission and then they'll have another therapy to try and remain in remission and keep them from having a relapse. If a patient has a favorable prognosis, they will have either a chemotherapy or a stem cell transplant for their consolidation. And if a patient has a poor prognosis, they're more likely to have both chemotherapy and a stem cell transplant done in the consolidation phase. If a patient does have a relapse or never meets the remission criteria, then it's recommended that they have a stem cell transplant. And again, this should be an allogenic stem cell transplant, meaning that it's from a donor, not from the patient themselves. Now let's discuss acute promyelocytic leukemia, also known as AML-M3. This is the most curable type of AML. We see up to 95% of patients reach complete remission with appropriate treatment. Some of the important distinguishing factors for acute promyelocytic leukemia is that it has a different induction treatment, which we'll be talking about in a little bit. These patients are at a higher risk of DIC, or disseminated intravascular coagulation, so that is a very important complication to be aware of. And the big distinguishing factor for this type of AML is that it involves the translocation of chromosomes 15 and 17, which confers that favorable prognosis. The treatment of acute promyelocytic leukemia involves all-trans retinoic acid, or ATRA, so a very different treatment than our other types of AML. Providers may also consider adding an anthracycline-based chemotherapy along with ATRA therapy for patients in acute promyelocytic leukemia. And that's going to depend on a lot of the different disease factors and staging. The main side effect of all-trans retinoic acid is the retinoic acid syndrome, which is important to be aware of. This usually occurs within a couple weeks of treatment and involves fever, dyspnea, and chest pain due to pulmonary infiltrates, as well as pericardial infusions. Retinoic acid syndrome is typically treated with glucocorticoids, chemotherapy, and supportive care. There is concern about an increased mortality, but if it's treated quickly, these patients will do very well. Chronic myeloid leukemia, or chronic myelogenous leukemia, also called CML. Chronic myeloid leukemia is a malignancy which involves the production of immature myeloid cells from the marrow. Unlike AML, CML occurs over a long period of time and has a very slow onset. It can be very insidious and have less obvious symptoms. CML is caused by the translocations of chromosomes 9 and 22 here, and this is called the Philadelphia chromosome, a very important term to know for boards. This translocation makes the formation of the BCR-ABL gene, which causes a mutagenic oncogene. This oncogene causes the production of tyrosine kinase to not turn off. So the patient has what is called an always-on tyrosine kinase production. This causes buildup of tyrosine kinase. Please remember the term Philadelphia chromosome is not 100% pathognomonic with CML. When you see CML on the exam, it's very likely that you will see the word Philadelphia chromosome or vice versa. But it is important to remember that the Philadelphia chromosome can also be seen in patients with AML and patients with ALL. And in those cases, it confers a very poor prognosis. So if you see Philadelphia chromosome or the translocation of 9 and 22 in AML or in ALL, it's a poor prognosis. However, it is a very good prognosis to see the Philadelphia chromosome in patients with CML. This slide just shows a representation of the translocation of chromosome 9 and 22 to show the formation of the Philadelphia chromosome, which makes the BCR-ABL oncogene. The clinical features of CML include a median age of approximately 55 years old. Also, signs and symptoms include fatigue, night sweats, fever, abdominal fullness, sternal tenderness, and splenomegaly due to infiltration of blasts into the tissues, as well as blurred vision, respiratory distress, and priapism, which are also due to leukostasis. Laboratory findings in CML include a CBC and peripheral smear with a leukocytosis. On the peripheral smear, you also will see a left shift, meaning that you have a lot of blasts or immature cells. However, in CML, the blasts at presentation are often lower than 5%, which means that you may not see them in the peripheral blood yet. Providers should also consider doing a leukocyte alkaline phosphatase score to help differentiate between a malignancy versus an infection. If the LAP is elevated, this would indicate that there is an infection. In the case of a malignancy, the leukocyte alkaline phosphatase will actually be low. The bone marrow is important in the diagnosis of CML, and it again will show a left shift, meaning that there's more blasts. Although the bone marrow will be hypercellular because there are lots of immature cells, there will be some loss of the good white blood cells as well. Cytogenetics for CML include FISH testing and possibly PCR testing of the bone marrow and bone marrow aspirate that will indicate that the Philadelphia chromosome is present. Proper staging of CML is important so you can make sure that you give your patients the appropriate treatment. This slide definitely has a lot of information on it, and the most important things I would like you to know from this slide is the stages and the blast counts associated with them. If there's a blast count less than 5%, meaning 5% of the marrow, then you know that your CML is in the chronic phase. If the range of the blasts in the bone marrow is between 10 and 20%, the patient is in the accelerated phase, and in the blast phase or blast crisis, we see a high amount of blasts, greater than 20% of the bone marrow. The treatment of CML primarily involves tyrosine kinase inhibitors, and these medications target the BCR-ABL oncogene that we discussed earlier. This oncogene causes overproduction of tyrosine kinase, so the tyrosine kinase inhibitors try and shut off that overproduction. The first-line tyrosine kinase inhibitor that is preferred for CML is imatinib, which is also known as Gleevec. It is able to inhibit the tyrosine kinase production and is very well tolerated by patients. There are several second-line tyrosine kinase inhibitors for patients in case they do not respond well to imatinib. The most common second line will be dasatinib. Patients who do not respond well to tyrosine kinase inhibitors may also require a bone marrow transplant. And again, we prefer that this be an allogeneic bone marrow transplant. This would be considered their third-line treatment. Furthermore, if you have a patient who is in a blast crisis, meaning they have greater than 20% blasts on their bone marrow, they may need to have more treatment besides just tyrosine kinase inhibitors, which would include the same medications you would use for AML treatment, such as cytarabine and anthracycline treatment. So in some ways, I tend to think of once the patients get to the blast phase, they really have an acute on chronic myeloid leukemia. They had chronic myeloid leukemia, but now they also have these blasts above 20, which kind of pushes them into that AML criteria, which is why they're treated with many of those same medications as AML. This slide is an example of an algorithm used to determine the treatment in CML in the initial phase. I do not want you to memorize this slide. This is just here for your information and to show you how some of the reasoning is done for making a treatment plan for patients. The response of patients to treatment for CML is divided by hematologic remission and cytogenetic remission. For hematologic remission, this means that the patient has a normal morphology of their blood, hemoglobin, and platelet counts. And usually we see this within weeks to months of treatment. So if you were to do a CBC and a peripheral smear on this patient, you would see that they've returned to normal. And you would also see that if they have any splenomegaly or hepatosplenomegaly, that this would regress over time as well. In cytogenetic remission, this has to do with the presence or absence of the Philadelphia chromosome or the translocation of 922. For this, it's graded minor, major, or complete remission. If a patient has a minor remission, then they have about 36 to 85% of their cells will still have the Philadelphia chromosome. If they have a major cytogenetic remission, they only have anywhere from about 1 to 35% of their bone marrow still affected by Philadelphia chromosome, and a complete remission means that there are no Philadelphia chromosomes found in their marrow. The discovery of imatinib was a game changer for the treatment of patients with CML. It was discovered in 2001, and after that point, we've seen a significant increase. Up to 80% or more of patients have remained alive or been cured of the disease. If a patient has a good molecular response, meaning that they do not have the BCR-ABL gene after treatment, they have almost 100% survival and can be considered cured. Next, we will discuss chronic myeloproliferative diseases. The chronic myeloproliferative diseases are divided into 3 types of disease: polycythemia vera, essential thrombocythemia, and primary myelofibrosis. Polycythemia vera. Polycythemia vera is an acquired overproduction of the red cells. This overproduction causes elevation of the red cell mass or very high amounts of red blood cells. In other words, think of it as the opposite of anemia. Polycythemia vera can involve the platelets and leukocytes as well. So you may see elevation in both of those cell lines, but the predominant elevation is in the leukocytes. The median age for patients with polycythemia vera is 60 years old, and it is a little more common in males. PV, or polycythemia vera, is also a tyrosine kinase mutation, but this one involves specifically the JAK2 mutation, and the gene is actually the JAK2 V617F. The clinical features of PV, or polycythemia vera, involve headaches, tinnitus, blurred vision, fatigue, plethora, engorged retinal veins, and splenomegaly. All of these are related to the increase in the red blood cell volume. We also see hyperviscosity that accompanies this increase in the red cells. You can also see symptoms of generalized pruritus in patients, and this is due to histamine release. And this is due to the increase in the basophils with this disorder. Patients will especially notice this pruritus during or after showering. The World Health Organization diagnostic criteria for polycythemia vera is listed here. The diagnosis of PV will require either all 3 major criteria or the first 2 major criteria and the minor criterion. The major criteria for PV is either an elevated hemoglobin, elevated hematocrit, or elevated red blood cell mass. Criteria number 2 would be bone marrow biopsy that shows hypercellularity. And major criteria number 3 would be the JAK2 mutation. The minor criterion involves a subnormal serum erythropoietin level. Again, the patient needs all 3 of the major criteria or the first two major plus the minor criterion for diagnosis. Here's the algorithm for the diagnosis of polycythemia vera. This algorithm is not something that you need to memorize. This is here for your reference. The diagnosis of polycythemia vera is made by the diagnostic criteria that we discussed on the last two slides. However, I want to highlight some of that information for you. So again, one of the main criteria for diagnosis is this unexplained increase in red cells, whether it be the hematocrit, the hemoglobin, or the red cell mass itself, the presence of the JAK2 mutation or some similar mutations which are listed here for you. The one I want you to know for exams is going to be that JAK2 mutation. A decrease in erythropoietin. It's also important when you're doing the diagnosis to rule out any secondary causes of polycythemia. So this could be things like a decreased plasma volume or hypoxia, smoking, or other tumors. Some other testing that may be helpful in the diagnosis of PV includes looking at erythropoietin receptor mutations, looking for bone marrow fibrosis, taking a CD34 count, and doing karyotyping. In the image here, I just wanted to show you an example of what polycythemia vera would look like on a peripheral smear. You can see that there is so much crowding in this photo here, and that there's just an overwhelming amount of red cells. They're really all overlapping, and you can't really make out one cell specifically because they're just so crowded. The phases of polycythemia vera. In the early portions of PV, it's known as the proliferative phase. This will often present with splenomegaly as well as hyperplasia of the bone marrow because there's so many red cells being produced. You also may see a thrombocytosis as well in the early phases. As the disease progresses, you'll see more and more marrow fibrosis, and this is because the marrow is producing and producing and producing until there's nothing left to produce and it's completely depleted. It's turning over so quickly that it eventually can't keep up. In the late stages of PV, this is known as post-polycythemic myeloid metaplasia, and this is a progressive syndrome. You see progressive hepatosplenomegaly, very, very advanced marrow fibrosis, and you end up seeing a pancytopenia because the marrow is so depleted that it can't produce any cells, even into the peripheral blood. Complications of polycythemia vera include thrombosis and bleeding, and eventually the progression to either CML or AML or the marrow fibrosis that we were talking about. The biggest concern with polycythemia vera is the thrombosis, and this is usually arterial thromboses, and they're a major cause of morbidity and mortality in patients with PV. This is mostly due to the increase in the red cells, but also can be further perpetuated by the increase in the platelets. There is the possibility of bleeding as a side effect later on in the disease because, as we talked about, there's initially increases in platelets, but as the marrow starts to be depleted, the normal thrombocytes are lost, and this can lead to bleeding complications. And of course, there is the risk for the progression to CML, AML, and also concerns for progression to full marrow fibrosis. The gold standard treatment for polycythemia vera is phlebotomy. And so what this is the removing of blood from the patient. This will significantly decrease the viscosity and also help with oxygenation ability. This is usually performed weekly for most patients and done until their hematocrit reaches a normal level, which is under 45. Patients can also be treated with hydroxyurea, which is used to treat the thrombocytosis. There's also the option of using allopurinol to treat any side effects such as hyperuricemia, which can result from the disease. There's also a new treatment option available for patients with polycythemia vera, which uses a selective JAK2 inhibitor. This JAK2 inhibitor is called ruxolitinib, and it has shown very promising results for these patients. Essential thrombocythemia. Essential thrombocythemia is a clonal myeloid disorder that is due, again, to the JAK2 mutation, very similar to polycythemia vera. But in this case, it causes only an overproduction of the megakaryocytes. This will eventually, of course, lead to overproduction of platelets. The median age of this disease is approximately 50 to 60 years old, and it is a little more common in female patients. As you can see in the smear on this slide, there are a lot of platelets, and there are many of them that start clumping together. So you can see just massive clumps of platelets in this peripheral smear. The biggest concern for patients with essential thrombocythemia is the risk for thrombosis or clotting. These are especially clots in dangerous and unusual sites such as the mesenteric, hepatic, or portal veins. Patients may also present with erythromelalgia, such as the patient in the photo on this slide. These patients will have transient blockages of the vasculature, especially in the extremities, that will result in redness and swelling. What this actually is small clots that come and go. Think of it kind of like a TIA of the extremities. Patients with ET can also encounter problems with bleeding. If all the platelets start clumping together, they can't function correctly and go to the places that they need. So in some cases, these patients also have bleeding issues. We also may see splenomegaly in patients with ET. The World Health Organization diagnostic criteria for essential thrombocythemia includes 4 major criteria, and all 4 major criteria must be met to give the diagnosis. The first criteria involves an elevated platelet count, so above 450,000. Bone marrow biopsy that shows proliferation of the megakaryocytes, which obviously will result in increased platelets. The diagnosis also requires that the patient does not meet the criteria for other myeloproliferative and a variety of other diseases, so things such as polycythemia vera, primary myelofibrosis, CML, and a variety of other diseases. And the fourth criteria is the presence of the JAK2 mutation. Essential thrombocythemia is treated with a variety of agents, the most common being hydroxyurea, which is used to lower platelet count. Patients may also be treated with a second-line agent, anagrelid, which is able to decrease the production of megakaryocytes. Patients may also be put on a low-dose aspirin to prevent complications from clotting. A patient with essential thrombocythemia has a near normal life expectancy if they do not have any of the major complications such as thrombotic episodes or bleeding complications. About 10 to 15% of patients with ET may progress to myelofibrosis, and this usually occurs about 15 years out from diagnosis. Patients may also possibly progress and need to be treated for AML, but this is usually about 20 years or more from diagnosis. Primary myelofibrosis. Primary myelofibrosis is an overproduction of the bone marrow. This will cause both inflammation and eventually lead to fibrosis. Initially, patients have fairly normal bone marrow, but gradually over time as overproduction occurs, scar tissue will form causing fibrosis of the bone marrow. If you do a peripheral smear on a PMF patient, you will see a leukoerythroblastic blood picture. This means that you have both elevation of immature white cells and immature red cells. Occasionally, you will also see teardrop cells on the peripheral smear, as well as poikilocytes and very giant platelets are present in patients with PMF. A bone marrow in a PMF patient will show initially hypercellularity. And this is because the patient is producing blasts or immature cells, both white blood cells and red cells. However, later on you will eventually see a dry tap for these patients because of fibrosis. However, it is important to differentiate this from the dry tap of aplastic anemia. In aplastic anemia, you will still have very fatty bone tissue on biopsy, even though it is fibrotic. This is not the case with the PMF dry tap. There will not be fatty cells, and also there's loss of the lymphocytes and plasma cells once PMF progresses. Patients in PMF may also develop hepatosplenomegaly, and the primary culprit for PMF is also the JAK2 mutation in most cases. There are some less common mutations that are implicated, but for the purposes of this course, I want you to know JAK2. For the WHO diagnostic criteria for primary myelofibrosis, patients must have all 3 major criteria and 2 of the minor criteria for the diagnosis of PMF. The first major criteria is the presence of megakaryocytic proliferation. The next criteria is that they do not meet any of the other criteria for essential thrombocythemia, polycythemia vera, CML or other myelodysplastic syndromes, or any other myeloid neoplasm. And then the third major criteria involves the JAK2 mutation or one of the other similar mutations. The minor criteria involve at least 2 of the following: leukoerythroblastosis, meaning they have a lot of leucoblasts or immature white cells and a lot of erythroblasts or immature red cells. Other requirements: an increased serum LDH, anemia, and a palpable spleen. Treatment of primary myelofibrosis. In the early disease states of primary myelofibrosis, most patients do not require drug therapies. However, they will occasionally need support with transfusions. This is especially true in patients who are anemic. Some patients will also need further assistance with erythropoietin to help increase their red cell mass. As patients progress, we may see more advanced disease and require some treatment with lenalidomide, which helps control the anemias and thrombocytopenias. In advanced primary myelofibrosis, a young patient, which would be under the age of 40, may be treated with an allogenic bone marrow transplant. Another possibility for PMF treatment is to treat with ruxolitinib, which is a JAK2 inhibitor. This slide contains an algorithm for the initial management of primary myelofibrosis. This is again here for your reference. This is not a slide that you need to memorize, but I just wanted to make sure you have this resource available. Myelodysplastic syndromes. Myelodysplastic syndromes is a group of hemopoietic neoplasms caused by acquired mutations. And these mutations will cause disruption in the maturation of the myeloid progenitor cells. Myelodysplastic syndrome will cause cytopenias in a variety of different types of cells. The median age for encountering patients with myelodysplastic syndromes is around the age of 65 to 70 years of age, and it is more common in male patients. Below is the World Health Organization diagnostic criteria for myelodysplastic syndrome. You can see there's a variety of different syndromes here, and this is not something that I want you to memorize, but it is something good to look over. The same is true for the diagnostic criteria by the French, American, British classifications for the myelodysplastic syndromes, which is on the next slide. It is, again, important to be familiar with these, but I do not want you to memorize this chart. Myelodysplastic syndrome does not have a specific set of clinical features to distinguish it from other cytopenias. Therefore, providers should be suspecting myelodysplastic syndrome anytime they're treating a patient for a low cell count that is not responding to treatment. Some of the signs and symptoms a provider can see in myelodysplastic syndrome includes symptoms of anemia. So those would include things such as fatigue or dyspnea on exertion. Symptoms of neutropenia, such as recurrent infections, and symptoms of thrombocytopenia. So those would be things such as bruising or bleeding, epistaxis, petechia, or purpura. The main diagnostic testing for myelodysplastic syndrome is a peripheral smear and a bone marrow biopsy with aspiration. The workup should start with a peripheral smear, and the provider will see a decrease in one cell line or possibly multiple cell lines, often neutropenia as well. The MCV that may be normal or increased on the CBC. A bone marrow biopsy will often show that there are increases in a blast or multiple blasts, and it is important that the biopsy also be sent for cytogenetics. There also is some additional testing for the workup of myelodysplastic syndrome. For example, if you're doing a workup for anemias, you should check iron studies, B12, and folate. It may also be important to check erythropoietin levels, but ultimately the diagnosis is established by doing cytogenetics, which will establish both the subtype of myelodysplastic syndrome and the prognosis for the patient. Karyotyping should also be performed for these patients. This slide contains a differential diagnosis list for myelodysplastic syndrome. The other diseases should be ruled out first before you diagnose myelodysplastic syndrome. So again, myelodysplastic syndrome really is a diagnosis of exclusion. Things to look at include iron deficiency, B12 deficiency, and folate deficiencies, sideroblastic anemia, especially those caused by alcohol or lead toxicity, any type of marrow dysplasia, which could be for a variety of reasons, and specifically concerns such as viral infections like HIV, drug-induced marrow dysplasias, chemically induced marrow dysplasias such as exposure to benzene. Patients with myelodysplastic syndrome should be treated with supportive care. These can include transfusions, especially for red cells and platelets. Other treatments include prophylactic antibiotics due to the neutropenia and infection risks. Patients are also likely to receive certain growth factors such as erythropoietin or granulocyte colony stimulating factor. Some patients with myelodysplastic syndrome will also be treated with bone marrow transplants if they are candidates. Transplant is really the only definitive treatment for those patients, but remember that most patients that are elderly are not candidates and healthy enough to have bone marrow transplants. And again, if you remember from the beginning of the lecture, these patients tend to be older, so a lot of them are not good candidates for bone marrow transplant. Another treatment that is sometimes used in myelodysplastic syndrome is certain chemotherapies, but in general, most therapies have been ineffective, and although it may help clear some of the issues, the problem of myelodysplastic syndrome is never completely cured with chemo, so they never really have a true remission. However, chemotherapy is helpful in delaying the progression to AML in many of these patients. There is one subtype of myelodysplastic syndrome called the 5q MDS that does have a good prognosis. The 5q MDS is typically seen in elderly women who have chronic macrocytic anemia and numerous large megakaryocytes. This subtype is caused by an isolated gene deletion, the 5q gene, hence the name, and these patients respond very well to lenalidomide. This medication activates the degradation of the casein kinase 1A and acts as a negative regulator of p53. p53 is the protein that regulates the cell death cycle, so it actually is a tumor suppressor. So the gene deletion is specifically targeted in the case of 5q MDS by lenalidomide. Overall, the prognosis for myelodysplastic syndrome is very poor, especially for patients who have refractory anemia with excess blasts. The typical survival for these patients is less than 2 years without a stem cell transplant. Often the patients who have myelodysplastic syndrome will succumb to other issues such as infection or bleeding. The only potentially curative treatment for myelodysplastic syndrome is an allogenic stem cell transplant. However, most patients are not going to qualify for this due to their age. Remember, again, this is a disease of the elderly. Thank you for listening to the Myeloid Disorders lecture for the Hematology and Oncology unit of the General Medicine course. Please be sure you've completed your study guide for this section so you are ready for the application session. Thank you.